welcome back to the panel. I think we can proceed to introducing maybe the next panelist. Professor Sipolish, would you like to do the introductions?
Sure, it's my pleasure. And thanks, Pavel, for assisting me in the room. Definitely, it's better to co-chair in these circumstances. So thank you, Gitte, for this excellent presentation. I can imagine some questions will pop up, and that's good for our discussion. But before that, and I think also since we have a nice set the scene presentation, it's good to hear also from others deeply involved in this. And I would start. We have three distinguished panelists there, and I would start with Kim Coopers, Associate Professor at the Faculty of Psychology and Neuroscience at Maastricht University in the Netherlands. The floor is yours.
Thank you so much for having us today in this panel and for the introduction. I did not really prepare something, but yesterday after the session, I was thinking about what we discussed yesterday. And I think that there were a lot of good points that came back today. Points that are not solely linked to psychedelic research, like when you have a trial, you need different doses, dose response. What we always do, and I think it's very important when you set up a trial, is that you assess the subject at different levels. You ask for subjective experience, you test objectively, you do computer tests, but also biological screens, so that you have a full range and that you can really define where the effects are. I also really liked a comment by Francois yesterday when he was talking about rare diseases. He really has a point that we should not only look at a mental disorder, but really should focus on symptoms. Mental disorders have symptoms in common. And that is really, I think, where we should move towards more transdiagnostic testing, not including only depressive patients, but just have a trial and include people who suffer from alcohol disorder, people who suffer from depression. That you just test, for example, the cognitive rigidity or the emotional dysfunction where people suffer from, and how psychedelics can make that better. There was also a comment that we should make use of the knowledge that is present, because ayahuasca and other substances have been used by other people for years, thousands of years. And I really think that is true, but I think for now, to get these substances approved as medicines, I agree with Guy Goodwin that we just should focus on the substance, have it approved, and in parallel run trials to really get the knowledge to the surface and develop develop good practices that we can use once these substances have been approved. And then, I have multiple other points. I also, but perhaps, just a couple of small ones. I really also do think that we should ask people to guess what they received, like Gitte said. But then my question is also, what are we going to do with this information? And for other trials, we also do not ask people. So that would be a question for you. What can we do with this knowledge? And I also think that we should be careful about the information that is given to patients when we run trials. I think we should not only be positive about psychedelics, but also the other trials that are given in parallel or to the other group. And that is the last remark. I also liked the comment that the support that is given should really be, we should be more transparent about what support people give. Perhaps you can publish next to an article as supplementary material, a treatment manual or what we did, but also report a percentage of, did we give more support to specific people? Because that is also not provided in articles. That were my thoughts until now.
Very good, very clear. We will have the opportunity to address them. And perhaps now we can move to Tomasz Palinecek, Head of Psychedelic Research at the Center of National Institute of Mental Health at the Czech Republic. Tomasz, the floor is yours.
Hello, good morning, everyone. I'm also glad to be here, and thank you for involving me in this panel. After the talk Gitte had, I've got some remarks, and maybe just to explain you a little bit of my background. I'm by education psychiatrist, but at the same time neuroscientist. And I'm involved in several clinical trials, academic clinical trials that we have designed. So we're kind of a role of a sponsor. So we know what we are facing when we are designing the trials, and also in the form of the PI of commercial clinical trials designed by the others. And there are several things that I've noted during the talk of Gitte. First of all, when we speak about clinical trials, it's not a real clinical situation. We do not treat patients in the same way as we are used to doing trials. One of the crucial things that is important to realize that clinical trials, we try to focus on very narrow population, but this is not the normal population that we are seeing in our clinical practice. There are many patients that might benefit from it, but they will just not be enrolled in the study because they fail on the inclusion-exclusion criteria. So it's very difficult to adjust inclusion-exclusion criteria, especially in populations like treatment-resistant depression, because anyone who is suffering treatment-resistant depression usually has some other comorbidity which might contaminate it, and it's very difficult to find clear depression. There's also an important role of concomitant medication, especially with psychedelic studies. Most of them were tapering medication, the classical antidepressant medication. But many of those medications are also used as a sleep aid. And if you can imagine that you have a patient that is suffering depression, you withdraw him from medication, he gets an effect of the drug, and then you have 3 months for follow-up, and you tell him, okay, you should be for 3 months on zolpidem, which is addictive. So this is also a thing that is very difficult to address in clinical trials and could limit maintenance of patients in the clinical trials. So the most important thing from this part, what I would like to point out is that just clinical trial is not real clinical situation. It's just rough estimation, and what we are facing in the clinical practice is very, very different. Thanks ketamine, we have the possibility to play a bit more clinically, because it's off-label, used quite a lot, and we use it quite a lot. You saw it yesterday in presentation of Professor Horacek. And we have experienced lots of possibilities with dosing and repeated dosing, and playing with the mode of form of administration, whether injecting orally or intranasal, and also starting with a low dose and then continuing with the high dose. And this is something where also clinical trials cannot address things like where the psychotherapy or support plays, because most of the trials that we are currently seeing, they're using just one dose, or they go for the open label extension, and there are 2 or 3 doses, the newer ones. And what is very interesting to see clinically, a patient that comes for the first dose and he doesn't know what it will cost to him, and when he comes for the 5th dose, and while during the first part of treatment or intervention that you perform with the patient, it's very interesting to see how preparation is important. But when he comes on the 5th time, that's not much about preparation, but it's about you can more play with the psychotherapy. It's much more relaxed. There's also a question in clinical trials how to appropriately design it. And ketamine, from our perspective, is a very nice active comparator. We have a trial, academic clinical trial, where we're directly comparing psilocybin to ketamine and midazolam. And it's very nice to see how both patients and therapists are thinking, what did they get? It's blinded, no one knows, but I can tell you it's difficult to recognize when you give the drug in a way that it has approximately the same duration of action orally to distinguish what was what. And I think that's something that we can offer in clinical trials. Going back to the clinical situation, which is now difficult in clinical trials, like there's something which we can call cost effectivity. Spending clinically tens of hours with one patient is something complicated. But when you think in a clinical routine, it will be much more effective if you have a group of patients which can be led by 2 therapists, and they take care about all of them, and they can also profit from group therapy in a long run. So this is something that it's very difficult to address, and will be very expensive to do in normal clinical trials. But I think this is what will come when these medications will be available, whether they will successfully pass the clinical trials, when they will be available for treatment. We're kind of playing with this with ketamine, and it's very interesting to see how that could work and how that could evolve, and also the role of negative experience in one session, from my perspective, doesn't mean it has to be negative on the other session. I saw that one session was negative, and the second session was quite difficult as well, and the patient benefited from the ketamine treatment. So there's lots of unanswered questions in this, and so these are my points.
Thank you, Tomasz. Very good points indeed. But before we go to them, it's time also to give the floor to Carolina Seibert, postdoc researcher at Champalimau Foundation, Department of Neuroscience in Lisbon, Portugal. Carolina, the floor is yours.
So, good morning, everyone. It's a great pleasure to be here and to be part of this thinking group, right? We are thinking. Last night, I went back to the hotel and was full of thoughts that I thought finally I can discuss them with people around me in an important place that will take decisions for patients and accessibility of these treatments. Just a little bit about myself. It is all true. I'm a postdoc researcher at the Champalimau Foundation, but my background was really, my PhD was in psychotherapy process and efficacy. So I really came from the psychotherapist part. I even dared to do a psychotherapy training that was psychoanalytically oriented in Washington, D.C. So I come a bit from very clinical research and very old-fashioned clinical way of thinking. And my second postdoc, which is the one I started at Champalimau, was the one that I started because I became interested not only in neuroscience, but in psychedelics. So this is my frame of mind, which I'm coming from. When I heard Gita's presentation, I immediately think of the challenges, the methodological challenges of that concern the safety of these treatments, that concern the efficacy, of course, and the accessibility. And the big question that jumps into my mind is that psychotherapy or psychological support in these clinical trials has been present. We are just submitting another systematic review where we looked at the type of psychological support or interventions that were being done. And it's clear that everyone is doing something with the psychedelic, or before or in the session and after the session. Some don't really mention or describe it. That's the point where we got that it's very poorly described what is being done. So the question is, what is the effect of the psychotherapy or the psychological interventions for this treatment? And this is a very important question, because it's and I think there are solutions to answer this question. I just think that there are poor resources to answer this question. I come from psychotherapy research, so I know how funding works. And I think of a clinical trial that was published 22 by Krapski on ketamine, maybe I pronounced the name wrong, that tested ketamine for alcohol use disorder. And I think it was a nice design to look at the effect of psychotherapy for this kind of interventions. He divided into 4 cohorts, where 2 got the placebo and 2 cohorts got the ketamine. And then he subdivided these groups into having a psychotherapeutic intervention or a psychoeducational approach intervention. And this is a very good example that it is possible to answer these questions or to get closer to the answer. So I think a lot of research has to be done, but I totally, and here I really, I think of my intervention yesterday, and I really agree with Guy Goodwin that we have to move forward with a simple design, so we know that this intervention, this psychedelic substances, whatever substance we're talking about, are safe for these patients with this diagnosis, and this. But we also have to look of what we are actually doing in the clinical trials and what we're doing then in clinical practice. And it is so important that these treatments, since I'm seeing that they work, we are still researching, but I'm seeing, and I'm kind of in my clinical mind convinced that they work, that we have to really test this hypothesis of the psychedelic with a psychotherapeutic intervention or with nothing, which is really not nothing, it's human interaction. And this touches my other point, which I'm very concerned about, which is safety, because it's exactly, so this is why we have psychologists in clinical trials. It's to help patients to deal with the adverse events so that we make the clinical trial safe. On the other hand, we also make it more effective. And that's the question, I already talked enough about it. And the other is exactly the 2 people in this room that are taking care of the patient are the ones that can also put the patients at risk. And this is why it's so important that this, whoever or whatever intervention is being done, is backed by a good professional, and a good professional has to respond to a professional board. And this is how we keep clinical interventions safe. This is how we know that nurses are doing a good job, social workers are doing a good job. They not only have a training, they have supervision, and they have a board that will take care if something doesn't go as planned. So I think for now, I touched the main points, and thank you for being here.
Thank you, Carolina. We have time before we break, so let's perhaps go to some questions. Pavel, I'm not sure in the room if there are some, but we could start by...
Yes, there are, Professor Spanish, that okay. We have activity, but let's maybe go to the room and then we can go back to you and see with the questions. First of all, we have an intervention from the panelists, and then we'll go to Maya. Yes.
I have just one comment, because when you, Carolina, mentioned the study about alcoholism and ketamine, it's very interesting to see the very first study that Krupitsky did with ketamine in patients. It wasn't actually a psychotherapy, it was an aversive therapy, and it also worked. That was very surprising to me.
So you have to see the interventions, right?
Yes, it's a good time also to remind people for the practicalities of the workshop. Please release your mic. Raise your hand high so we can see you in the room, and raise your hand online if you want to speak so we can pick up. So Professor Polish, we have 3 interventions planned in the room, and then we can see also online. Starting here with Marta Hojek on the right. Thank you very much. Sorry, Maya.
Thank you. Good morning. My name is Maya Kohek. I come from the International Center for Ethnobotanical Education, Research and Service. I was just wondering about one thing that was told in the end, that the professional, the nurses, the people that take care of the participants, the patients, at the time of the acute effects have to be well trained and know how to deal with the situations that may occur. And then I'm thinking, but these same people were in their education, they were taught that psychedelics are dangerous substances, and now I suppose that we would need to re-educate them about this. So how is that planned, or how we will address this issue? Thank you.
I think that's a very important aspect. Having me, even talking about myself, having my background and highly educated in psychotherapy practice, I needed a training to know what to do and to know what kind of treatment this is with psychedelics. So this is, of course, but that's the piece where when we it is a training, it is an additional training, and I think it can be a simple training, which doesn't mean it's simpler. It's just something that can be done additionally to the clinical background, because knowing the disease and knowing the diagnosis and having clinical experience is equally important, in my opinion.
Thank you.
Just can I add to this? It's very interesting to speak to old psychiatrists, old-fashioned biological psychiatrists who say, well, we have seen psychedelics in the 50s and they didn't work, they failed. And they don't go to the literature which says the opposite. That's one thing. So they're convinced that the only treatment they do is the standard one. This is good. And we are kind of crazy. I think with the younger generation, it's quite normal. And me as a doctor, if I say diamorphine is a prescription drug, which is used in England and some other countries, but in fact it's heroin and no one cares. So I think it's just we need to get used that this situation comes on place, and medical specialists will get the knowledge and get trained. And I think our students, at least medical students, they are very interested in this topic more than the old-fashioned psychiatrists.
Thank you, Guy Godwin from FPA. Thank you.
Hi, I'd like to just get back to some of the issues around trials and get to just a couple of questions, really. The first was, you show rather less variability between the intensity of experience and receptor occupation than you show between intensity of experience and blood level of psilocin. Can you comment on that? What do you think the cause of that is? And then just secondly, a more practical point, because of that variability that we see between dose and experience, it isn't true invariably that people know what dose they're getting. And indeed, we found with the 1, 10, 25, there's a lot of confusion, both the people observing the patients and also the patients themselves. We didn't, unfortunately, formally record that, but it's certainly true anecdotally from all the sites that recruited significant numbers of patients. So I think it's different when you have 25 milligrams in placebo, but certainly when you have several doses, that is actually quite blinding. And the variability is our friend, but I'd be quite like to know whether you think that's due to differential brain penetration, whether that's a real source of variation in the experience. Thanks.
Thank you. I think that's a great question. And I also want to emphasize that I brought up the example because I thought it was a brilliant design. And I didn't mean to say that you could kind of guess what you were getting. I think we see quite a lot of variability in both measures, but mostly in the subjective experience. I think we see some difficulties, particularly with people who never had an experience before, and they don't know what to expect. And often what we see is when people rate their experience, they say, oh, I think this is a 10. No, this is a 10, and so on. So it can actually be a bit tricky. And also when the receptor occupancy starts to level off, you can have quite variable plasma concentrations. I think it's remarkable that you can make a single occupancy curve based on different individuals. That was a surprise to me that it actually seemed to fit on to this very same curve. So I don't think there is a whole lot of variability when it comes to absorption and blood-brain barrier penetrance. I think that's quite stable. Otherwise, we wouldn't see such a relatively consistent pattern that would adapt to the single site model. I don't know if that's answering your question.
I hope this answered the question. Moving on here with questions. First, I have on my left Kevin Craig from Life Science.
Thank you. Yes, Kevin Craig from Itai Life Sciences. I wanted to follow up as well with Professor Knudsen and Guy's comments just on this idea of dose response studies. I think, knowing the placebo problems, it sounds like a great idea. And, I look across at diabetes and things like that, where you see beautiful dose response. But I think it's very difficult in this area because, we have this variability in PK and we have a variability in the treatment outcome as well. And it seems like, there are rigorous designs that we could use for dose response, like MCP mod, which we haven't seen so far. But I think it is very difficult to actually demonstrate that in psychiatry. Even, in the Spravato program, they took about 10,000 blood samples and they did a big exposure response analysis and it was uninformative. And then there's this other approach, which is to, use a sub-threshold dose or a sub-therapeutic dose as a comparator. And I think that speaks to, the uncertainty and the blinding. But I was interested from a regulatory perspective about whether you see a distinction between, using a dose that might leave some equipoise in the treatment allocation versus a true dose response methodology.
Just one comment back from maybe just one point just back from the clinical perspective. We have patients that respond to normal doses, but we have also very sensitive patients that respond to very tiny doses. Like, for example, mirtazapine, which is a very useful antidepressant, very effective. It's also used for the sleep help and as a sleep aid. I see many patients that just benefit from half of the lowest dose and they still have reduced anxiety and even though it's sub-threshold dose. So I think we also cannot catch within the small sample sizes which are in clinical trials the whole population, and this is kind of there are people that are very sensitive to everything and they could have responses to very low doses as well, and there are also placebo responses. We saw a healthy subject on psilocybin in our psilocybin trial that got placebo and he was experienced and he had a full psychedelic effect on placebo, and on the second occasion when he gets psilocybin, oh, this is even stronger. So even in experienced subjects, they can have such feelings, which is also interesting.
Yeah, and maybe I can add one way to try to adapt to this point is that there are trials where they are given 2 doses. So you could imagine that you would have first giving a lower dose and then a higher dose. That's at least one option that has been used in the past.
Thank you very much. I was going to just say the same, that it's also true for placebo, and we can have this with placebo as confirmed by the panelists. Now, moving on, we have a question from Eduardo Schemberg. You're on the right. Eduardo, where are you sitting?
Here.
There you go.
Hello. Eduardo Schemberg, Brazilian neuroscientist, formerly at Imperial College with David Nutt, currently at University College London. Carolina, I'm really happy to hear that you're coming up with a review about the psychological and interpersonal aspects of this therapy. And I would like to bring a note of caution and care because I think we have a debate since yesterday, sorry, about these 2 different concepts. But actually, it was not demonstrated with data and evidence that psychological support is different, how much is different, where is it different. And as we've written in the issue at the American Journal of Psychiatry in January this year, the practices might be similar, but I think for the regulators, if this is scaled up and implemented as psychological support, that could lead to one kind of consequence. And if that is regulated and scaled up as psychedelic-assisted therapy, the consequences could be very different. And I defend the opinion that psychological support can bring much more risk when it's scaled up, and the practices that will come after the clinical trials, which are always very different than what are done in the highly controlled studies. Thank you.
Thank you. Very clear. Moving on to another intervention, we have Professor Nutt here on the left, and then another couple of interventions from the same side. Thank you.
Yeah, thanks. Well, there are quite a few issues we need to think about. I mean, the first, could we all agree we don't want the term hallucinogen used anymore because it's irrelevant and it's pejorative and it's certainly not necessary to the therapeutic outcome. So if we could get rid of that term, that would be very helpful. I mean, there is also this interesting emerging evidence of efficacy at what we would typically call sub-psychedelic doses. So we've just completed an OCD study giving people 10 milligrams of psilocybin, clearly a psychoactive dose, but certainly in almost none of them a psychedelic dose in the conventional sense. And we do need, I think, to get some clarity in our thinking around how we would view that dose. And of course, that will also feed into what's likely to be a continued dialogue about neuroplastic doses. And if we don't get clarity now, it's going to become more confusing as more of this work is done. I want to also talk about the nocebo. Gitta mentioned nocebo, but my interpretation, and maybe Guy can feed into this, my interpretation of nocebo is that it's not just when you get placebo and you wanted psilocybin. It's when you get psilocybin or some other psychedelic and it doesn't do what you think it's going to do, which is cure you. And my interpretation of some of the adverse effects in the Compass trial was that people were over-expecting. I'd be interested in Guy's comments on that. And then the final point to make about, I think from a regulatory perspective, there's a really critical issue in how you do trials. Now, we've seen a number of trials, and Gitta mentioned this, where people are promised the active ingredient at the end if they don't get it at the beginning. Now, it's not clear to me what the regulatory position is on those as registration trials.
Let's try to address these points one by one. Also getting, Professor Spolich, getting close to the coffee break, we can and we probably will move some of the points to the discussion later. But first, is there a response from Guy Goodwin here on the direct question, and then we can tackle maybe the regulatory question?
Yes, sure. I mean, the way we've thought about this is that you get nocebo in all three arms, in that it's disappointment. We're not talking about adverse effects, which is usually the context in which people talk about nocebo. So the question is really, we should be looking at patients who actually get worse from baseline. So we've done that fairly systematically, and we see no difference between the people in the 25 milligram group and the 1 milligram group who don't respond. In other words, there are not more people who actually get worse in the 1 milligram group than in the 25 milligram group. So whatever nocebo is, it seems to be equally distributed across those arms. I would be very interested to see whether this is true in the placebo-controlled trials, because if you look carefully at the USONA trial, there is sort of provision. Looking at one of their plots, it would appear that twice as many people in the placebo group actually got worse from baseline than in the 25 milligram group. And I think this highlights quite an important difference between a placebo control, true placebo, and a low dose control, where the expectations are different for the patient. And I think, we're giving the patients a Bayesian task, which is to decide what dose they have had. And if you give them a very precise task, placebo 25, they probably do that discrimination better than if you give them a more uncertain, a less precise challenge, which is to detect 1, 10, or 25. And that was the thinking that went into the way in which we designed our study, which was expressly to get around some of the issues that have been discussed today. So let's not treat them as if these have been never thought about before or addressed. That was what we were attempting to do with the design of our phase 2 study. And it will also be the design of one of the trials in our phase 3 study. Thank you.
Thank you very much. Professor Polish, from the regulatory side.
Oh, yes, I was. We have the pleasure of having in the room the head of the SNS, working party, Andre Elfring. Can I push you to give your perspective also from a scientific advice working party perspective on the regulatory question that was just put forward?
Well, I didn't catch it completely, so that you have to repeat the question. But maybe Marion?
So,
Shall I?
Yeah, well, first the question, because I still have to.
I think the question is about the kind of trials we do need about the placebo and the nocebo effect and the dose finding. You don't hear it?
No, my question was, there are two trial designs. There's the trial design, which, very effectively was developed by Compass and to some extent us. And there's the trial design, which the most clear example, I suppose, is the Bogenschutz trial of psilocybin in alcohol use disorder, where initial randomization was to either an active placebo, diphenhydramine, or to psilocybin. But the arrangement was that at the end, if you wanted, you could get what you didn't get, and I guess most people who got diphenhydramine would have wanted to have psilocybin at the end of the trial. Now, that kind of design where people know that at some point in the future they will get access to a psychedelic is quite a different design, and I'm not clear which is better. Certainly, I think the offering everyone at the end to have one treatment probably improves retention, but I'm not sure whether that's acceptable in the regulatory framework, and that's the question I'm asking.
Well, I'm not sure I fully get it, but if the question is that the expectations of patients are different when they get in the future in the same trial the active compound, but in the beginning not. Personally, I would say that's not a problem, because if you show a separation in the first part from the active treatment, placebo, or the low active treatment, and you see a separation, then there's evidence of efficacy. And I think that's the first thing you have to show. And I think the discussion would be very difficult as well. The study population is not the target population, but because in practice you are not offering the treatment at a later time stage and you are not manipulating expectations. In my opinion, that's irrelevant, actually. You have shown an effect, and I think that's what we. So
then it just boils down to the interesting question as to what extent the effect is contaminated, or the power of the trial is contaminated by people staying in the trial who would otherwise have dropped out. And I guess that's a question that individual researchers need to think about then.
But I don't see the methodological problem in if you show a treatment effect. Yeah. So, and we decide on that. So I don't see major flaws that you have incorporated this, let's say, artificial target population.
No, you're right. It's
study population.
The reason, well, so I think one of the reasons why that future treatment offer design exists is to maintain people in trials. Now, that's a different trial design because you've got greater compliance with the placebo, and therefore you can't really extrapolate between the two kinds of trials. But I take your point. If one works, you may lose power in having the expectation, or the group that will eventually get it. You may lose power. I mean, it may just become a question of numbers then, and resources rather than anything else. Yeah.
Well, thank you. I'm aware that there are many interventions. I have had at least 5 people waiting. My proposal, Professor Polish, is to break as planned. And then we have, as we know, quite a few opportunities to intervene more than 2 hours, and everybody's going to get their turn, instead of rushing some of the interventions and not allowing for people to receive answers. So if this is acceptable from your side, Professor Polish, we call a
Very
short
acceptable.
coffee break, and we come back here at, let's say, 11 o'clock.
So welcome back, everyone. I can see at least the panel seating, and I can imagine most of you are already back to your places. I hope you had a nice break and gain perhaps more ideas or insights for our discussions that will follow. So we still have more time, and there were already questions in the room. But to kick off, perhaps, and going back to the core theme on the methodological issues that we faced when designing these trials, perhaps we could kick off with 1 or 2 questions and then take it from there. And my proposal was perhaps to go back to some of the issues raised by Gita in her presentation. And for me, there are 2 aspects that perhaps we could start clarifying or seeing where we all are in terms of reasoning. The first one would be a question on how should we adjust the duration of these trials, taking into account the psychedelic experience? Should the trial designs be adjusted to the duration of the psychedelic experience? And this was something I'm sure Gita would like to address. And there's also a second one that perhaps if there's time, we could also try to talk a bit, because yesterday the question also popped up in one of the discussions, which is, can we identify patients that are more likely to benefit from psychedelics and others that are less likely? Because this will translate most probably not only into the trial design, but also into the therapeutic indication that we will get. And I heard yesterday some of the members in the room here today would probably feel that we're targeting, for instance, depression-resistant situations, while we could move into other indications that are perhaps not so last line. But I think it is important to discuss this, what patients would benefit most, and can we identify them? And that will be very helpful for the design of the trials. So Gita, without further ado, I saw you move, and I give you the floor.
Well, thank you so much. Yes, I showed the slide where the duration of the psychedelic experience, how it looks in relation to different compounds. And obviously, some of them are given intranasally or even IV. They're going to have a more short-lasting duration. I think that we still, I mean, obviously, whereas all these compounds target the serotonin 2A receptor and induce a psychedelic experience, there's still some interesting preclinical data out there suggesting that maybe the psychedelic experience itself is not a prerequisite for the therapeutic action. We still need to see more convincing data when it comes to that question, but that would be the extreme version of having no psychedelic experience but still having therapeutic benefit. Until we have more firm evidence that this is something that can be considered, we can only discuss the duration of the psychedelic experience depending on these different compounds. And I think even the qualitative aspect of it, although people cannot really distinguish between doses and compounds, then there are also some qualitative differences that one can observe with these different compounds. And the short-lasting compounds obviously have the benefit of necessitating less time during the session. An LSD session can be very long. It's a full day. You cannot possibly have sitters sit there all day long with them. You have to exchange them under the way. And some of the short-lasting compounds are also reported by people to have a very rough onset, which can be slightly disturbing. But time will tell. We are waiting for some of the results from, say, 5-MeO-DMT to see how that works. There are also some preclinical data suggesting that the therapeutic effect because of reopening of critical social windows matter for how long the therapeutic effect lasts. We also need to see if that holds true in patients and in people. So I think there are some really interesting aspects that will become much more clear as we get more data in the future. But it's something to keep in mind that it's not just about psilocybin and derivatives, and we'll see we'll have to see what comes out here. It's going to be very exciting, I think. Regarding the patients and who are the right patients, I think we can have that for a separate discussion. But maybe someone else wants to add to the duration of the experience and the compounds.
Professor Nutt, on this topic?
Well, yeah, I mean, this is a really complicated area. There's no such thing as a short-acting compound, or at least you can make DMT, which normally lasts 10 minutes, last for 4 hours. We've done a 6-hour infusion. So the concept of short acting is too trivial a concept. We have to define the duration of administration and the dose in order to really get some clear perspective on what is actually happening. So could we get rid of the term short acting and long acting and just define what we're actually doing, please?
Sure, you can do many different paradigms, but we need to find a term that is appropriate, of course.
So we could talk about clearance, I suppose. We could talk about half-life disappearance, but that probably isn't going to help us very much either. So I think we just need to have a clarity as to what we're actually doing. And so, for instance, our original psilocybin work showed psilocybin was cleared in 30 minutes, so IV. Is that short-acting? I mean, is that... People aren't using it IV for other reasons because doctors don't like to inject things IV generally. But I'd like a little bit more science in this field rather than simply talking about. And in fact, originally ayahuasca is long acting. That's the whole. I mean, the DMT originated as a drink which you can take for hours. So let's try to be a bit more clear as to.
But let's talk about the duration of the psychedelic experience, no matter how it is generated. And as I said, there might be some qualitative differences. Also, some of these compounds are different pharmacologically. They target not just the 5-HT2A, but they also target other receptors in the serotonin system and other systems. So that could add to the qualitative differences that some people have reported. But nevertheless, the issue still remains. Do you need to have a psychedelic experience of a certain length in order for it to be effective? Can we confirm what seems to be the case, at least in some mouse studies, that this is related to the therapeutic duration, etc. So I think these are the issues that are interesting to discuss.
Thank you. I've seen a reaction from Dr. Habenkamp, maybe addressing.
Yeah, exactly. That is a very, very interesting question. And as I try to explain, and there's a little bit of semantics around the word maintenance of effect and how long does it last. So it is, first of all, of course, the duration of the psychedelic experience, how long is it really needed to get an effect? And then, of course, we can characterize as according to the concept of rapid-acting antidepressants, if we speak from major depressive disorder, if the effect starts like on the first or second day on the depressive symptoms, that is something which we need to disentangle from the psychedelic effect it has. So what is the effect on the depressive symptoms, and how early does this occur? And we see it with other kinds of rapid-acting antidepressants that we see something after 24 hours, for example, also for postpartum depression. And there are products in development where we see it on the second day. And that is quite different from what we see with SSRI, where the effect starts developing after 2-4 weeks. And there we see the effect. And so we need to characterize the early onset, the onset of effect, and the duration of the effect. First of all, the psychedelic episode, but also the effect on the depressive episode. If we speak of major depression, is it an early onset, and how long does it last? And and is this during the episode, the maintenance then kept? Is it for 4 weeks, 6 weeks? Do we need retreatment, or even for 3 months? Does it last longer than the current used antidepressants? And that can be studied in different designs, I think. So we need to disentangle that a little bit.
Thank you. Very clear. I have here Thomas on my right, and then Amir later.
Yeah, thank you. I have several points to that. First of all, duration of the effect could be important in terms of the psychological content which is in there. If you have most of the studies show that peak experience or mystical kind of experience is important. But when we look into the microphenomenology and we want to implement it into psychotherapy in the future, then the content, it could be very important. So the longer duration, the more likely to happen something important during the sessions. That's one thing. The other thing is, which just comes from the basic pharmacological mechanisms, like there's the acute effect, the rapid onset effect, which I feel is kind of a mood switch. It's a functional brain state that switches from one state to another. But then there is this duration of the effect, which we believe now is related to the neuroplasticity. And obviously, if you treat something very quickly, that is less likely to induce prolonged neuroplastic effect than if you introduce something that lasts for longer. So I think these two things are complementary and cannot be separated completely. And we should work with something which is called afterglow or the acute effect, and something which is a lasting effect. And also we can learn from ketamine studies when one ketamine dose is shown to have an effect for about a few days, up to a week. But the more recent schedules are using ketamine in repeated dosing regimes, and the duration of the antidepressant effect is prolonged. There are prolonged ketamine release novel compounds or novel formulations that also could show sustained effects. So there's lots to learn and lots to think about for future.
Thank you, Dr. Palinček. Dr. Inamdar.
Yeah, very quickly, I just wanted to share some data that we generated with work with DMT on this issue of intensity and duration. It seems that there are two variables, intensity of the experience and the duration of the experience. And it may very well be a play between the two, which eventually results in the therapeutic effect. So if you've got a very intense experience, that lasting for a shorter duration can still be therapeutic. But if you've got a less intense experience, then you need that experience to last for a longer duration for it to result in therapeutic efficacy. Of course, these are just preliminary data that we've seen, maybe something worth exploring in the community.
Very clear, thank you. Dr. Havrot.
Thanks. So, a couple of points on the kind of variables. One point I wanted to make is overlapping with Tomasz already mentioned. To some extent, I think, when you speak about duration, one thing is how fast the substance clears out from the body. But, this is a paradigm for other treatments. You have an active substance and it clears out. But of course, with psychedelics, we have also neuroplasticity. We have psychological effects, which have it's a separate issue when it comes to the duration. I also want to speak to removing kind of psychedelic effect from psychedelics. I think here we should also dissect better what does it mean, psychedelic effect. Do we want to remove hallucinations? Do we want to remove time distortions? So there are many different parameters that we could tweak and maybe, find something interesting there. And I also want to, in the last observation, speak to something else that Gita mentioned in her presentation, where she alluded to, that we need a better understanding regarding suicidality. I think this is a really important point. So I hope that we all agree that psychedelics are very powerful substances and they need to be approached with great care, and we need to kind of tread carefully and also avoid some mistakes maybe from the past. And for me, one of the main risks maybe also in terms of the kind of public perception is not communicate the risks properly and kind of upfront. And so here, it seems to me that suicidality is one of very real risks as we speak about, substance clearing out from the body. It's not necessarily, something that can be kind of related to suicidality, because we know that even if the substance is no longer there, psychedelics are experiences that can be very destabilizing psychologically. They can disarm people, defense mechanisms which are there for a reason, and sometimes we are not kind of ready to confront too much and too fast. So even if these mechanisms usually outlive their usefulness with time, so and people confront their traumatic experiences and so on. So I think it is not surprising that in some cases suicidality can increase, and there will be, when we will see hopefully the rollout of these treatments, there will be probably very likely suicides, there will be deaths, car accidents, and we need to, as a community, be clear about this. And also, of course, and this can happen even with the best safeguarding possible, but we perhaps should still think about how we can go an extra mile and try to think how we can mitigate this more. And I'd be also curious to hear maybe from Guy Goodwin, because, in the COMPASS study, there were some issues with suicidality, if he has anything to say about, how we could be further mitigating these issues. Thank you.
Yeah, thank you. Yes, I suppose the issue is that we measure suicidality using a particular scale, which I think is designed to be sensitive. Just to be clear, in our own study, which has 233 patients, there were no actual attempts at suicide and there were no suicides. So when everyone talks about suicidality, it's kind of sub-threshold in our study. We look very carefully at the pattern of the change in suicidality over the course of the trial in all our patients. And there was a weak tendency, which was not statistically significant, to see greater changes in the 10 milligram group than in the other groups. And the 1 milligram group had rather low changes. I don't know really what to make of that. We will look at this further in larger studies and we will be able to report back. How to interpret these changes is really quite difficult. What we do know is that we had at least one case, and I can talk about this because she has gone very public about it, and she had a very difficult experience, and she represents one of 79 patients who received 25 milligrams of psilocybin, but it's a cautionary tale. And I think it's not unexpected, given the literature that already exists on the informal use of these drugs, which reports, quite a lot of examples of people, often young, often taking the drugs in unsupervised environments, having really quite prolonged destabilization of mood, not necessarily suicidality, but destabilization of mood. Where you take a depressed population, which of course we did, and a treatment-resistant one at that, your risks are obviously greater that this instability of mood will be translated into increased suicidality. So I think it's a reality that we have to be very cautious about, that a few patients, given these very powerful drugs, will have a very bad trip, if you want to use that word, and they may have really quite difficult outcomes. They are made worse by the drug. Mercifully, this seems to be very unusual, but it's a reality. And what we will have to do in clinical studies is to make sure that we get the necessary support for those people outside of the treatment protocols to make sure that they're looked after. And that is the most important issue in terms of patient safety. And I think going forward, what we hope we will be able to show to the regulators is that balance between benefit and risk. And this is going to be one of the risks of using this treatment. And we have to be completely honest about this, and we have to be transparent about it, and we have to measure it. And we also have to do it at scale. And it's also the reason why we should not be short-circuiting these drugs into clinical practice, and we should be maintaining their use within clinical practice. So just that's my perspective on this.
Thank you very much. Professor Podesz, I hope that we managed to cover the question you posed from a number of different angles. And if this is the case, we have people who have been waiting for intervention in the room before the break, and I'll be happy to give the floor to them if you agree.
Absolutely.
Okay, thank you very much. Of course. I start by Magda here on my left. Can you please introduce yourself and pose your question?
Yes, thank you very much, Magda Rosenmüller from the Business School in Barcelona. We are partners of the PsyPal project, and our experience lays in bringing in how to manage the take-up of innovations in the healthcare system, and looking into the settings, the needs, but also the further scaling. My question is, so I'm a medical doctor also by my background, and it was fascinating to listen to. I missed yesterday, but to listen to Gitte and others, and I had already discussed my question a little bit during the break. When we see the large variability and also the subjectivity of outcomes, and that's what we actually measure. Does it work? Does it not work? How does it work? What does it make work or not? What makes us to have problems or challenges. I wonder if it would not be interesting to put more of these data together in a platform of all these experiences, as all these clinical trials. Not necessarily will that tell us exactly, but it will guide us on what type of different clinical trials design we should do in the future in order to identify. We just heard from Guy that there are some unexpected events, and just to maybe be able to identify better what could be the causes for that, and then we could apply the technology with artificial intelligence has done an enormous jump in the last years. So. Couldn't we do this like the rare diseases, really bringing more of the experiences in a platform together that will guide us and help us to better move forward on many of the aspects we have been hearing this morning? Thank you.
Thank you. So if I understood you correctly, you're asking the panelists, but probably not only the panelists, the people also in the room and online, whether there are any initiatives, I would call them, that are planning to bring the data together for the benefit of everyone and use them. I'm also very interested to hear if there are any such initiatives. Any comments from the panel first?
I think Gitte knows the best because there's this ECNP group on psychedelics, which has this as one of the key questions to be solved.
Right. Well, I think that we should all be strong believers in data sharing, and particularly in an area like this where numbers are not yet that large, it's really important. So we are in the in our working group, which is governed by ECNP. We are looking into how we can share our data, and this is already happening to some extent. But obviously, this is on an academic basis. And when it comes to companies, obviously, it's slightly more complicated, I guess. But I would really like to invite anyone from companies working with these substances to contact the working group, and we would be really happy to look into that. I think there's a lot to be learned from these. As we already heard, a lot of the variability, I believe, comes from the different pharmacokinetics that people do actually show quite different profiles. And it would be an advantage to have plasma concentrations available so that would ease the comparison, I believe. And as we've seen, it's also quite well related to the occupancy on the receptor site. So I think that kind of information is particularly useful when we want to compare across studies to the extent possible.
Thank you for the very clear message. Joost Breckman has been waiting for some time. Joost?
Thank you, Pavel. A couple of comments. So I think we should be cautious of oversimplifying what we're talking about. Psychedelics induce complex subjective experiences, and I think we know what we've seen from many studies is that intensity is not correlated with therapeutic effect or therapeutic outcomes. So even though studies show nice correlations between receptor occupancy and intensity, this does not automatically translate to therapeutic effect. And I think what we're interested in is meaningful therapeutic experiences and positive treatment outcomes. So that's one point I wanted to make. And second, I was really glad to hear Guy Goodwin mentioning the need for post-trial therapeutic support, because that's something that we also hear when we talk to patients. They often really struggle in the period immediately following the clinical trial, also following the psychedelic experience, especially in the absence of any continued psychotherapeutic support. And so within our SciPel consortium, we have luckily managed to include this. So this is a publicly funded trial where we will be given setting up peer support systems for patients in the post-trial period. My question is, when trials are sponsored by pharmaceutical companies, whose responsibility is this to ensure this post-trial support? Because there is a need. I think it's important to emphasize this explicitly. There is a need, not for everybody, but for a meaningful percentage of patients. So is this something that that pharmaceutical companies, for instance, regulators, should fund and support? Thank you.
So starting the answer from our side, but if we approach by companies and this is identified, obviously we'll request that they commit to some sort of support because we are committed to providing public health and being catered for. But how is it done on the industry side? Is there any will to help me with this or to answer? I think it's part of the standard approach anyway, Amir.
Yeah, it's an interesting issue. As clinicians, we of course want to maintain continuity of care, and we try in our clinical trials that there is the concept of a warm handoff. Typically patients, and this is not new to psychedelics, it's an issue with all clinical trials. When patients complete their clinic, during the trial, they get an enhanced level of care. When the trial finishes, then it's more or less cold turkey for them. I think we have to be careful right now because with every intervention we make in a clinical trial, it comes with a cost. Cost is quite prohibitive right now. These studies with psychedelics are one of the costliest studies I've ever seen run in the industry in the past 25 years or so. And the industry, psychedelic industry itself, is struggling for funding. There are quite a lot of examples right now. When I was looking at this a couple of years ago, there were about 72 companies working on psychedelics. They have distilled down to a handful in the past 2 years. So if we impose certain requirements on companies to fund post-trial support for patients, it could essentially put them out of business and then bring to a standstill this field of research. I'm just being very blunt and honest about it based from our perspective. I'm not saying nothing needs to be done. We absolutely need to find a way to do something. And the middle ground that we found right now is to ensure that there is a warm handoff. When people finish their clinical trial, we take care that they are handed over to their primary care physician in a way that sort of ensures continuity of care and they are not left in the wild.
Can I respond?
Challenge is understood. I didn't see the intervention. Where did it come from? Yeah. Yeah, is it Joost? Okay, sorry.
Sorry. I wanted to briefly respond to Amir, because I see your point, but I think there's also, there may be an interest from in your case, Cybin's side also, to see a maintenance of effect, and that can be achieved by providing prolonged psychotherapeutic support. And this is something that I don't think we know yet, how to maintain effect over time, but I think cutting off psychotherapeutic support may be a limiting factor, and also I think a warm handoff to regular care may be insufficient for patients who have had very sometimes overwhelming and profound psychedelic experiences. So it may be a little bit different in the case of psychedelics.
Let me summarize to say that we recognize that there are challenges, but also we have responsibilities. So we see what the best approach forward is and for everyone. Yes, please, Carolina.
Yes, just to add a little bit on the investigator's perspective of having to fit funds and fit our costs for these trials. It's really, it becomes really, really hard. And I think there are two solutions or pragmatic solutions. One is just to accept participants in our trials that are already in psychotherapy or in any form of psychological support or psychiatry support, and we have to define that criteria, which will add up on the inclusion and exclusion criteria. So I'm not so happy with that, but it makes me feel safe as a researcher. And the other is to ask the insurance of the clinical trials to cover that. And I think that second one is a bit too optimistic, but I just wanted to voice this concern on the investigators. It's really difficult to make the meets end, yeah.
Since we're talking about patients, and I've seen Jan wanted to jump in, and let's hear indeed from your side.
Yeah, I think aftercare is incredibly important. As Joost mentioned, we hear it all the time. A lot of people come out of the trial process and they go from the isolation of living with their chronic health condition, and even if their condition has improved, they then go to the isolation of going back to their social groups, their family groups, nobody really understanding what they've been through. You may have a very supportive group, but it's a bit like, kind of liken it, if you can explain what it's like to go to Paris to somebody, but you can't actually place them there, and some people have no support whatsoever from their immediate social circle. So that feeling of abandonment and isolation is very keen and it's very common. The majority of our network, our community, are people that have sought us out post-trial. We're building good relationships with trial providers to directly refer or mention us at the end of trials. But most people have sought us out because they're like, this is the beginning of my therapeutic process. They want to carry on. They want to be in spaces where people understand what they've been through. They want to be in a space where people aren't judging them or rolling their eyes. So I would say that we do see funding that aftercare, however it looks, as a sector-wide responsibility. And I think there's a balance to be struck, really, because yes, it's one thing saying, well, if the sector's funding this as well, then many organisations might go under because they can't afford to maintain that. But also, if you have an increased number of adverse reactions, 6 months, within 6 months afterwards or whatever, or people nosedive, and there is no adequate support there, then that could also derail these treatments. One way of going about addressing that is peer support, as Joost mentioned. As an organisation, we're looking to run a peer support pilot study ourselves in the next couple of months. Hopefully that's going to be successful and it's something we'll be able to roll out more broadly. But yeah, I do think, that's going to cost money to do that. We don't want the cost of that to be prohibitive because we want it to be open to people of all, economic circumstances or whatever. So yeah, it's I think that if we don't think about aftercare at all, then that could also lead to these treatments heading off the rails as well. So there's a balance to be struck there, and I'm sure we can find a way.
Thank you very much. Professor Spoller, just for your awareness, we continue to have a number of interventions that are waiting, but at any point, if you want to also intervene from your side, and also I wanted to stimulate the people online that we're also monitoring that. So just give us a signal, because we don't want to prioritize only the people who are physically in the room.
No, there's WebEx is keeping very calm, so we don't see any hands raised. So if you have more interest in the room, please proceed.
Thank you very much. So I spotted George Goldsmith from Compass Pathways at some point. George, thank you.
I will defer my comment for later. Thank you.
Good, thank you very much. Then I have Francois on my left. Francois, you're address.
It's a comment about this contradiction between the practical difficulties of granting continued access to the investigational product after the end of the trial and the ethical requirements, both by the World Medical Association and SIOMS. They all require the trial sponsors to make all provisions for patients who benefit from a treatment or those on the comparator arm to continue to have access to treatment at the end of the trial. And ethics committees should verify that these provisions are in the protocol. So we understand these difficulties, and they are not unique to psychedelic products. They exist in all domains, in all disease areas, and really this is a dialogue we need with academic and industry sponsors and regulators. How can we solve this contradiction between practical and financial aspects on one hand and ethical requirements on the other hand? Because at present we are living as if we don't want to see the issue, but we need to find solutions in this for these situations.
Understood. Thank you very much. Then I head to Robert Schoevers for UMCJ.
Yes, thank you. There was the discussion went about standardizing, and then it went to data sharing. But I think in the field there's a lot of activity at this moment to see if training and training modules and treatment protocols can be aligned across different projects and studies. And I think that is really something to be commended for our field. And I think we could agree on main ingredients that will be found across studies. And I know there are some upcoming papers that try to formulate that. So I think that's helpful. The other thing that came up was adverse effects and whether patients are optimally prepared for the experience. One of your panel members, Carolina Seibert, wrote, I think, a very relevant paper on this in Nature Medicine. And maybe you could share that perspective also, as it's, I think, highly relevant for how we design study protocols.
Thank you. Yes, this is a very, very important aspect. And just to give a little bit of context, this paper happened because there were a lot of media coverage of patients that didn't have that good experiences, and they didn't feel that they were taken care of. And even further, this relationship of trust that usually is built in a treatment setting was taken advantage of, right? And this is something that can happen not only on the level of intimacy, we know that, so I come from psychoanalysis, the old psychiatrist and the young student or the young patient, but was also taking advantage of this relationship in terms of financial agreements. And so this boundary violation is really cross-sectional. It's not only about sexuality. So this made me really think there's something wrong going on, because all clinicians learn the good rules, but we know that not everything we learn is what we do. So let's write something about it. And here I started to read the literature about informed consent. And there was a group of researchers in the US already writing 2 or 3 papers about this. And I started to think, and us as a group also started to think, what would be the important points of this informed consent? What is so special about these treatments? And so the first aspect is to have an informed consent and to have a bit of a broader information that is given. Because in psychotherapy, we know that we use informed consent but sometimes it's limited, it's rushed. And here with psychedelic treatments, I think we have to be careful that we're preparing a patient, a human being that is not well, for experience that is, I would say, unpredictable. I always give this example because I'm a woman. It's the same as, or it's very similar, I would say, to prepare a woman for giving birth. So you cannot prepare for the physical pain because it's different for every woman. You cannot prepare for the psychological distress it will be for the bodily transformation. So in this, back to the paper, really the guidelines to have informed consent that prepares for the unpredictable, I think, is the bottom line of this informed consent. Explain also what are the adverse events, right, without making it also like reading medication prescription and looking at all adverse events. We often see patients that don't want to take their medication because of that. So it's a very delicate exposure of what is expected to happen in this session. And the informed consent can also be a moment of building trust that we know that there is something that's going to happen that is different, but the other person on the other side doesn't need to be afraid, or he or she will be well taken care of. I think this is something, the informed consent procedure, or a bit of a widened informed consent procedure, is something that happens in clinical trials and has to be well designed to also happen in the clinical practice where there's less time, there's more rush, but patients need to be well informed what is expected, and they have to feel that they are in the position to say, you know what, I thought it twice and I don't want to do this, so I'm going back to my regular treatment, or I will hope for something else. So give the patient also the freedom to know what to expect and to change his or her mind.
Thank you, Carolina. I've had Professor Stützeberger on my left here for some time. Professor Stützeberger.
Yeah, thank you. I'm the Chief Medical Officer of SciBiopharma. The following will be a personal statement. Great workshop, and thank you for the opportunity of having this exchange. And very happy to hear that now in this session we come to talk about how can best practices be established across clinical trials, across psychedelics in an accelerated way, because I think that we talked about the time that has been lost due to the illegal status of the compounds, and I think now some time has to be made up. And I wanted to talk mainly about the privilege of the regulators to see across clinical trials, as long as they are registered with you, to see the regular safety update reports, to be able to look into benefit risk earlier than the public will ever know, and making sure that the learning across projects is kind of transformed into living guidelines which establish best practice for studies running and studies to come in a good way. I'm very fond of having this voluntary approach as well of data sharing, as you just mentioned it, Gitta. I know from my times in multiple sclerosis how long it took with the Sylvia Laurie Center before the industry was willing to share their data, to allow the appropriate meta-analysis, to allow the joint learning. And I think beyond all these voluntary approaches of the master protocols that were just gladfully be mentioned, the development of best practice for ethics committees to have plausible concepts of follow-up therapeutic caretaking, it will be, in my view, very important. And I would like to hear from you, the regulators, what you can do to make the learning quicker and to come up with guidelines. Just take that point of placebo or dose guessing. We here said, yeah, maybe it should be there. So maybe it should be in the regulation. You need to have a very good explanation why you are not doing it. And when you are doing it, these are the robustness analysis we want to see in your dossier to understand what the effect of dose guessing or placebo or treatment group guessing was. So what can guidelines do to make sure data sharing happens under your protection through your learning and through your feedback to the community to inform best practice?
Thank you very much. I would start, but then I'll also advise all the regulators in the room, but also Professor Polish, if you can continue. First, a clarification of what our guidelines can and cannot do. And one of the important things we are trying as regulators not to do is limit innovation by over-regulating with guidelines. So if you just say, why don't you put this and this in a guideline, we will, when there's a sufficient level of evidence that it actually is the best way forward. So any recommendations that are made by the guidelines have to be data-driven. So for that reason, I fully agree that once we get the data, the signals, everything points to a certain approach that is, let's say, optimal at least, or recommended. We can provide guidance in any form, not only in guidelines, but we have to be careful to not limit or even stop innovation. And this is not a small balance to be achieved. What we can do, a number of initiatives, but certainly we cannot replace what was mentioned before, the need for collaboration outside. It cannot be the only way that the regulators are expected to be the only collaborative space. We can enhance and we can participate, but I think it was very well pointed out by different stakeholders that collaboration outside on a different level should be also driven in order for those data to first achieve the level of evidence and to be gathered in a way that they are actually usable. And that's my general comment. I'll look around the room to see if there's any specific comment, but for now, I think it's very clear that we haven't planned any specific guidelines on this topic because we're still in the data gathering phase. And it was mentioned by Dr. Haberkamp earlier, we will try to reflect the knowledge in the specific guidelines that we already have. And if we reach a stage where a specific committed document is needed, of course, we'll consider it. Dr. Haberkamp, and then maybe Professor Polish or Dr. Elferink if you want to intervene. Thank you.
Yeah, I can only reiterate. I mean, we try to give it a start with the depression guideline where we put some thoughts in, but since we do not have anything approved yet, we do not know the optimal way where we can give guidance how to design the studies. We look at the scientific advices and what is submitted, and we gave it a try to give our first identified our thoughts on the first identified problems we see. And we do not recommend like the golden way because we don't know it yet. And so we are very open to discuss various approaches. And that is what our guidelines are about, the regulatory guidelines. They are not a law. They are not like very prescriptive. They are recommendations that once we know how they should be used, are recommended to be followed. But we are still open to other approaches. And all these aspects we discussed around, like the blinding, the comparator, the most appropriate study design. These are very common with all other kinds of developments. So taking the specific characteristics of the psychedelics into account, these are also very specific safety concerns that might also not be easy to address fully during the trials, but there might also be post-approval activities needed, post-authorization safety studies. What are the long-term effects of like plasticity induced in the brain that cannot be characterized like in a half-year study? We need to long-term safety follow-up, and this can also be regulated with risk management plans and post-authorization safety studies, and we have to closely follow this, and that is something which is also important.
Thank you. Short comment from Dr. Elferink, maybe?
Yes, well, guidelines usually are reflecting the state of art based on the knowledge what's there. So what is already happened and what is already established. As said, what is the golden way? If you are uncertain what to do, or if you realize you deviate from the guideline, which of course is acceptable, but you want feedback, the policy is made in the scientific advices, I would say, because there you can give your arguments why you deviate from the guideline, give your arguments why you have a completely new setup, give your arguments why you have this and this comparator, and that will be weighted there, and we will give an advice there. I think at this stage of development, I think the scientific advices are more appropriate to address these discussions than the guidelines. So that was my addition.
Thank you very much. And Professor Polish, you wanted to make a point as well.
No, it's very fast. And building on what Marian and Andre just said, I fully agree with this last statement. Scientific advice remains our best tool at the moment to even consider future updates of guidelines. But I think for that, we have two other tools that are major aspects we need to consider. First, early dialogue with all developers, and please come forward if we do not see the products for, questions for scientific advice. If we have no chance of giving opinions on the trial designs, it's more difficult to have this knowledge transfer. And it will also be a more difficult marketing authorization process. So when we have this at hands at marketing authorization, when we have discussions on benefit risk, when we have all of that, I am sure the knowledge transfer will happen, and we are open to that. So guidelines are developed based on what we also learn from these interactions. So not only early dialogue, but the other aspect is engagement with stakeholders. What we're doing today is also very helpful for us, the regulators, the same way we hope it's very helpful for all others in the room. But this engagement, not only with the European authorities, but also with others, like we had yesterday, FDA colleagues, and Australian colleagues, is extremely relevant. So from our side, there's openness to that. It's a learning curve, and again, scientific advice, going back to what Marian and Andre just said, remains the best way of shaping future guidelines, and this is where we are. Back to you, Pavel.
Thank you very much, Professor Polish. I'm aware that we're getting close to the break, but I have at least two opinions here on the right that I don't want to omit and give them the opportunity to speak. Nanko, and then followed by Erik Vermeten later. Thank you.
Yeah, I would like to get back on the topic of the duration of observation and reporting of safety events, and then also connecting that to providing information for subjects that prior to being treated with psychedelics. First of all, the duration of observation is, in the current trials, is not related to the duration of psychedelic effects, but most trials observe patients at least up to 3 weeks or even up to 12 weeks. So they should be able to pick up in at least the active trial phase negative effects of coming out of psychedelic experience. And the question is then, how long do you need to follow up, and how long can you actually feasibly follow patients up within the trial? So that needs to be determined. And since you are comparing treatment, different treatment arms, there is only a limited window where you can actually keep the integrity of the trial. So after that, you have to hand off. But of course, if there are negative experiences, they should be recorded as adverse events. And then we have the obligation to follow those up and ensure that care is provided, whether they're in the trial period or even after. So that, according to regulation for all trials, that should be taken care of. Then I get back to also what I mentioned yesterday on recording the experiences in order to provide the prescribers and the patients with the information. So how should we record the experiences during the psychedelic part of the administration and the safety aspects afterwards? Is this a different way of collecting data, or should it all be as adverse events? Should we use scales? what is the regulator's current view on how these data should be collected in order to be able to put them in the SMPC and provide the information?
Well, at least on the safety we can discuss later. I think that the way we reflect the SPC, the information is the SPC will probably not differ much for psychedelics as we do for other compounds, but we need to be certain on what is identified as an adverse event and what is identified as an effect, intended effect. And at this point, I don't think that we can talk and say much more. Okay, Gita will help me.
Yeah, I think this is a super important question, how to register the adverse events and how do you define an adverse event. So we've just been struggling with the very same issue. And obviously, if you note that there is any event just after the experience is over, there will be some people reporting on hopelessness, also people who are not having a diagnosis, but healthy volunteers. And how do you cope with that? Because the experience itself can lead to thoughts and experiences that are not really that pleasant to have. So I think it's a super important question, but it's also hard to address. And I think it's something that maybe we in the ECNP working group could spend a little time thinking about and getting some input from people who are running trials as well to see if we could maybe jointly define some of the ways whereby one can report it. And there are scales out there that you can use for describing the content of the experience that I think should be used and that are being used. They've also been shown to be predictive of the long-term response, antidepressant response. So that makes a whole lot of sense. But I think it's really something that requires more work and consensus.
Professor Polish, I've seen hands being raised, but if you allow me, I'll allow maybe 1-2 last interventions, and then I can hand over to you for final words before we close this session. I've seen Eric Vermetten wanting the floor, then Amir as well, and there was another reaction on the left. So let's be quick so we don't delay lunch. Thank you.
Yeah, thank you, Pavel. I'd be happy to defer my question to after lunch. That'd be fine as well.
Great, thank you very much. So then we had Amir very quickly.
Yeah, just on the issue of adverse event reporting, I think the complication is many of the expected effects of or on-target effects for psychedelics would otherwise be considered as adverse events if it were not for the psychedelics. So in a different working group, we've sort of taken a three-pronged approach where there is, of course, a need to characterize the acute experience because this is the information that will be necessary for the prescriber. We need to tell the prescriber what to expect when the drug is given. So we are recommending to at least our investigators that they collect information about the acute effects, irrespective of whether they think that is on target or not. The other approach is also to look at defining adverse effects as you would normally define adverse effects, any untoward medical occurrence. And for on-target effects, which are during the acute phase, if they persist beyond the duration, expected duration of the acute phase, or require any sort of intervention for the safety of the patient, then they immediately become an adverse event. And then there is a third category, which is adverse events of special interest. We keep talking about potential abuse liability, and there are usually terms provided to investigators, to sponsors, about what would need to be collected as abuse-related terms. So we collect them irrespective of whether we think they are adverse or not. In the interim, until we come up with a better option, this approach is working well for us and maybe something worth considering by the larger group as well.
Very clear. Thank you very much. One last approach before lunch. And I have here, if I'm not mistaken, Anton Escolar. Thank you. Can you please present yourself?
Thank you very much. This is Anton Gómez Escolar, a psychopharmacologist and scientific advisor from the Spanish Society of Psychedelic Medicine and the Inaue Foundation. I just wanted to add a few comments on the discussion about the length of the experience and the pharmacokinetics. I totally agree with Professor Nat that labeling molecules on the length of the effect is increasingly inaccurate because, as we know, we have methods for having longer or shorter experiences with the same molecules. And also with Dr. Brixima, with his idea of being careful of talking too much about the kinetics and forgetting that this is an experience that has many, many different qualities and effects and aspects that are not just in the kinetics. No? But regardless of the length of the experience, I think that it's very important also to keep in mind that the speed of the onset and the intensity of the onset can have a very great impact on the quality of the experience itself. So this is a very important variable to keep in mind. How fast is the molecule acting, how strong is acting, because this can lead to difficult experiences somehow, or it can lead to bad quality experiences for the therapeutic outcomes. Also, the experience can be very different if the patient is with a needle for a continuous infusion, for example. The quality of the experience can be impacted by what are we doing to the patient in order to keep that trip extended. No? And also to keep in mind that we have very interesting tools for studying the different variability that we can find with substances depending on the length. For example, the so-called trip killers like ketanserin that may have some impact also in the experience itself, but it's interesting to know that we have these tools that can help to shorten an experience to see if it's different or not in the outcomes compared with the longer one. And just last question, there is. Now I feel that a very big limiting factor for clinical trials is the training of the participants, the clinicians, training for administering psychedelic substances and supporting the psychedelic experience. And I wanted to ask if the EMA has any plan to support somehow standardization of the training practices for these clinicians, because probably this is going to be needed in the future when it comes to training future clinicians administering these treatments to the general population. Thank you.
Thank you very much. A very Solomonical response to this is that we will require the standardization to be present, and how we can participate in this we should probably discuss on a case-by-case basis depending on the needs. I thank you for this. Professor Seporish, not that there is no interest in the room, but I think we can defer a lot of the questions to the second stage of the workshop. So back to you for the final remarks.
And thank you. And this will also help us to keep the fantastic track of time that we've been keeping yesterday and today. So again, thank you very much for this lively session. I'm really sorry that I wasn't there, but these hours went by so quickly. And this not only shows the interest, but also the commitment of everyone gathered here today to make sure this topic will move forward. And in terms of methodological aspects and the challenges that we identified here today, it is good to see that we are also generating possible responses to these challenges, that we will also, at the end of today, try to very briefly summarize, and we will follow up on these. So with this, I think it's time to close the session.